At Royal North Shore Hospital in Sydney, we have been using gallium-68 DOTAtate imaging since 2010 in patients with neuroendocrine tumours. In this short presentation, I want to give you an update on a preliminary analysis of a study that we're doing, a trial looking at the impact of cold somatostatin analogues on the biodistribution of gallium-68 DOTAtate PET imaging. A bit of background. So when a patient is diagnosed with neuroendocrine tumour of lower grade, grade 1 or 2, the usual treatment that commences is a long-acting somatostatin analogue. This is often used to control the hormonal symptoms that patients get in a carcinoid syndrome, and also is regarded as being anti-proliferative. That is, it suppresses the metastasizing nature of the disease. So generally therapy with lutate comes in after the patient's first-line treatment with long-acting SSAs is no longer holding the disease in check or controlling the symptoms. The treatments for long-acting SSAs involve a so-called depot injection, where the patient is given an injection in the buttock every 4 weeks. The dosing varies from between 30 to 120 milligrams at a time or more, and this covers the patient for the 4 weeks or so. Now, historically, we've all tried to do our imaging of gallium-68 DOTAtate and our therapy as long as possible after the previous long-acting SSA injection, with the theory being that the long-acting SSA may be occupying some of the receptor sites, and so that if we wash that out as much as possible, we should get better uptake on our PET imaging and better uptake with the lutetium therapy. All this contributes to making scheduling a little bit tricky, because sometimes patients forget to not have their next injection, and then we have to delay their treatment or their imaging and so on. So if we could actually assess whether this actually did interfere in any way, it could make the scheduling of the department a lot easier. So the aim of this investigation is to look at the impact of somatostatin analogues on gallium-68 DOTAtate biodistribution. To do that, I felt that we needed to actually define the reproducibility of gallium-68 DOTAtate PET on our system, where we use a Siemens MCT biograph, about 160 to 200 megabecquerels of gallium-68 DOTAtate, with scanning performed approximately 60 minutes after injection. So the study is called the Bayonet trial. This is the cover page from the study, and what we are doing in this study is looking at patients who have previously had lutate and so have been exposed to large amounts of radiation, or patients who are about to have lutate in the next few months. And the reason for doing that is that we didn't want to have any problems with the ethics committee in terms of excess radiation, so we argue that the extra gallium DOTAtate scans that they have are contributing very little to their overall total radiation burden, given that they are being treated with a radionuclide therapy anyway. So if the patients already had about to have their treatment, what we do is we get them to have their standard of care DOTAtate scan, and then within a couple of days we bring them back and we get them to have a reproducibility DOTAtate scan. So this is typically about 3 days after the baseline scan, standard of care scan. Without any intervention, without any injections, they come back, they're not on any drugs, they come back and they have a standard, again, DOTAtate scan. And then we arrange for them to have their depot injection of their long-acting SSA, and about 3 to 5 days after that, we get them to come back for that scan to see if the injection of the long-acting SSA is having any impact on the biodistribution. Now, the reason we chose that time window of 3 to 5 days or so is that is when the company Ipsen, who's sponsoring this trial, suggested that the blood values are likely to peak for the long-acting SSA. So we figure that that's the time when there's the most receptor occupancy. Now, we're looking to enroll 25 subjects in this trial. So the methods that we're using at the moment, we are using a thresholding method on the Hermes workstation to define volumes of interest on up to 5 target lesions, and you can see that on the lesions out of many that are in the liver on the left-hand panel there. And we're also defining these for normal liver, spleen, muscle, pituitary, adrenals, kidneys, and these are all organs that have high uptake of DOTAOctreotate physiologically. The Hermes analysis gives us a lot of parameters such as SUV max, mean, and peak. Today I'm only going to talk about SUV max because that's what most people relate to. We look at the differences relative to baseline and calculate what the average differences are, looking at the reproducibility between the scans as a percentage, and then we're displaying these using the Bland-Altman methodology of difference versus average. You can see one of the organs, the spleen, defined in the right-hand panel there as well. And so we're taking the SUV max from these large volumes of interest. So to date, I'm reporting on 5 subjects who've been recruited. You can see the 5 subject scans here. This is their standard of care scans. The scan number 2 has a particularly high uptake in liver, and therefore the rest of the uptake is being suppressed in the display, but we think that physiologically it'll be equivalent to the other patients. You can see a lot of hepatic disease in these patients, some with distant metastases, all with prominent pituitary gland, kidneys and spleen in particular, and excretion via the urinary bladder. So here's an example of one study, the baseline standard of care scan on the left, the scan done just 4 days later with the dates along the bottom, showing you the reproducibility scan, and then finally 6 days after that, a couple of days after they've had their long-acting SSA, they come back for the post-SSA scan. So the things that we're going to be looking at are the difference between the baseline and reproducibility to see what the repeatability is like, and then the difference between, I'm actually taking the average of the baseline and the reproducibility versus the post long-acting SSA scan. So the results shown here for reproducibility, firstly on the left-hand side, the average versus the difference for the normal tissues, that is the liver, spleen, kidneys, adrenals, thigh, muscle, and so on. You can see that there's very minimal bias of -0.4 SUV max in units, and the coefficient of repeatability, which is plus or minus 2 sigma, is set at plus or minus roughly 4.5 SUV units. The average difference over all of the observations here is 2%. On the right-hand side, the lesion SUV max variability is a little wider, as you might expect, because these are smaller VOIs that are being used, and so, but also the bias is still very close to 0, indicating no bias between the studies, which is probably what you would expect if you're just looking at repeatability of the same scan twice. Here, the coefficient of repeatability is roughly 8 SUV max units. So that is to say, if you want to compare a lesion to say whether it's progressing or not, you really would need it to be more than 8 SUV units increased or decreased, whichever way it's gone, to be outside of 95% confidence that that is an actual change. When we come to looking at the long-acting SSA, we don't see much difference. The bias, again, is very close to 0, indicating no bias, and the graphs are very similar, and I'll show you those compared in the next couple of slides. And a little bit more of a bias in this study on the lesions, but still only 1 SUV unit. And remember, we're talking about a plus or minus 8 to be a significant difference from the repeatability study. So again, no differences are really being seen there. Here I'm displaying the normal tissues next to each other, whereas before it was normal and lesion. This is normal repeatability on the left versus normal effect of the long-acting SSA on the right. There's very little difference between them, and again, unbiased. And the same thing for the lesions, showing you a very similar sort of pattern. As you can see, most of the SUV max values are below 40 in these patients, with just a few above that at higher levels, but still within the limits that we think are required to consider a significant change at the 2 sigma level. So in conclusion, in this preliminary series of 5 patients, which have been pretty difficult to recruit over the past few years, the long-acting SSAs appear to have no effect on uptake and biodistribution of DOTAOctreotate. So this is really contrary to what our practices are in most NET centres. Most people will try and wait between 21 to 28 days after the previous injection because they're concerned that the long-acting SSA might have some impact. There have been some anecdotal reports when patients have forgotten to not get their long-acting SSA and so on, but not in a controlled manner, and that showed very little effect as well. So it seems to be bearing out those anecdotal reports, but this is being done in a more systematic and formal manner. If this continues to be the case, then scheduling can be revised to make it much more simple. We really don't need to worry about when the last long-acting SSA injection was given. The patient can have their scan at any time during the month and their therapy. The repeatability index shows us that we need to really have a shift of plus or minus 8 units or more in the SUV max in lesions to represent a change at the plus or minus 2 sigma level. And that's something that we can convey to our reporting physicians when they say, look, you know, the SUV's gone from 15 to 20, is that significant? The answer is probably not. You need a bit more. And again, SUV maxes are single values, so they are going to be more susceptible to statistical variability. And because we're struggling a little with the recruiting, this has been going for about 18 months to get 5 subjects, and we're hoping to get 25. We're looking at opening up recruiting to other NET centres to increase our enrolment. Thanks very much.